Welcome to the deep dive. Today, we're immersing ourselves in a really clinically challenging area of medicine, managing diabetes during pregnancy. This isn't just about chronic disease. It's a high-stakes balancing act where, precise control of maternal blood sugar dictates the future health of two people.
It really does. And our foundation for this deep dive is going to be excerpts from a key text, Diabetes in Pregnancy, the complete guide to management, edited by Lisa E. Moore. We're going to try to distill the complex science and the rigorous clinical protocols for you, really give you the essential roadmap from preconception all the way through postpartum.
Okay, let's unpack this. So our mission here is to move beyond just the textbook definitions. We're going to break down the specific pathophysiology, master the management protocols, including that critical mental math for insulin dosing, and really confront the significant fetal risks.
Absolutely. And to understand gestational diabetes, GDM, you first have to appreciate what a normal pregnancy does to metabolism. Because as the pregnancy progresses, well, all women experience a normal physiological decrease in their insulin sensitivity.
And it's a huge drop, isn't it? Something like 50 to 60%.
A massive drop, 50 to 60%. But you're right, it sounds bad, but it's actually a brilliant evolutionary design.
It's meant to happen.
It's meant to happen.
Yeah.
That resistance ensures that enough glucose, the baby's main fuel, gets pushed across the placenta to the fetus. The system is working as intended.
So the problem with GDM is when that normal process gets layered on top of something else.
Precisely. It's when this normal, massive physiological insulin resistance is superimposed on a woman who already has some degree of pre-existing glucose intolerance. Maybe it was latent. Her pancreatic beta cells just can't keep up. They can't produce enough extra insulin to overcome that combined resistance. And that's when she crosses the line into, frank diabetes.
I find the molecular mechanics of this just incredible. Can you break down how the placental hormones are actually physically blocking insulin at the cellular level?
Yeah, it's like a hormonal assault against the cellular machinery. So when insulin tries to bind to its receptor, the IR, it's blocked. You get this decreased expression and phosphorylation of the IR, and that leads to reduced activity of something called insulin receptor substrate 1, or IRS1.
So the signal just gets weaker from the get-go.
The signal is weakened. And that's key because the ultimate downstream effect is decreased translocation of glucose transporter 4, GLUT4.
The doors that let the glucose into the cells.
Exactly. Think of them as the doors. If the signal is weak, those doors don't move to the cell surface, and glucose just piles up in the bloodstream.
And which hormones are the main culprits here, the ones leading the charge?
Well, the placental hormones are the key metabolic antagonists. Cortisol levels can go up 3 times the non-pregnant value, but the biggest player is human placental growth hormone, HPGH. It increases up to 8 times and actively interferes with that critical PI3 kinase pathway.
The very system insulin needs to work.
The very system.
Yeah.
And on top of that, we see elevated leptin and low adiponectin, all of which contribute to more insulin resistance.
So when that maternal hyperglycemia goes unchecked, the consequences for the fetus are severe. This is where we get into diabetic embryopathy.
And this is where the stakes become crystal clear. Maternal hyperglycemia acts as a powerful teratogen. It increases the risk of fetal anomalies by 2 to 4 times.
2 to 4 times. Wow.
Yeah, and the most serious defects involve the cardiovascular system and the central nervous system.
And the data on this is really, really strong, isn't it? There's a linear relationship specifically linked to blood sugar control in those first few weeks.
Absolutely. The period of organogenesis, the first 8 weeks, is so incredibly sensitive. The stark numbers show that the risk of a major malformation is 40% when the first trimester HbA1c is over 14.4%.
40%.
Compare that to a risk of just 3% when the HbA1c is less than or equal to 9.3%. The recommended threshold to slash that risk is getting the HbA1c below 6.5%.
Which makes that preconception window absolutely non-negotiable. If the first trimester is the highest risk, then optimizing control before conception has to be the best strategy.
It truly is the best intervention we have. That preconception visit is a critical opportunity to get things optimized while the patient is highly motivated.
So beyond hitting that strict HbA1c goal of less than 6.5%, what are the practical mandatory steps during that visit?
Medication reconciliation is paramount. Statins have to be discontinued immediately. And for women with, say, chronic hypertension or established diabetes, we have to stop drugs like ACE inhibitors and ARBs.
And why is stopping ACE/ARBs so critical before pregnancy even starts?
Because they're known phytotoxins. Especially in the second and third trimesters, they can cause potential renal damage to the fetus. So we switch them to pregnancy-safe options. things like labatol, methyl-dopa, or nifedipine. These are crucial because they also offer renal protection to the mother.
And of course, you need to assess for any existing diabetic complications before the stress of pregnancy begins.
Exactly. This means a dilated eye exam to rule out proliferative retinopathy and a 24-hour urine collection for protein and creatinine clearance. We have to know the baseline.
Okay, before we jump into the active management, let's just quickly differentiate the underlying types of diabetes.
Sure. So type 1 diabetes, T1D, is that autoimmune destruction of the beta cells. We can confirm it with low C-peptide levels or the presence of anti-beta cell antibodies like GADIA or IA2A.
And they need insulin to survive.
Correct. Then you have type 2 diabetes, T2D, which is characterized by insulin resistance plus a relative insulin deficiency. And there's a huge genetic component there. If both parents have it, the offspring's lifetime risk is up to 70%.
Okay, let's talk management. If diet and exercise fail, rapid intervention is key. First, those glycemic goals, they are famously tight.
They have to be tight to minimize fetal exposure. The core targets are non-negotiable. Fasting blood glucose, it's got to be less than or equal to 95 milli-GDL.
Okay.
1 hour after a meal, less than or equal to a 140. And 2 hours after a meal, less than or equal to 120.
Those are incredibly difficult targets to meet. So how often are patients checking their blood sugar to try and hit those numbers?
For GDM in type 2, the minimum is 4 times a day fasting and after each meal. For type 1 patients, it's much more rigorous. We're talking 7 times a day. Fasting, pre and post meal, plus checks at bedtime and even at 3 a.m. if we need to rule out nocturnal hypoglycemia.
So when is the trigger to start medication? You can't wait too long.
No, you can't. Intervention is needed when 20% of all values, or 20% of values for a specific testing period, say just the fasting values, are above goal for 2 weeks straight.
2 weeks.
And we really emphasize that that delay is critical. 2 weeks is 5% of the baby's total time in utero exposed to high glucose. It's significant.
So for medical learners listening, let's get into the mechanics of insulin dosing. This is where those mental math shortcuts become so vital.
Right. Insulin is the gold standard. We start by calculating the total daily dose, or TDD. A basic starting calculation is the patient's weight in kilograms times 0.3 to 0.6 units per day.
And once you have that TDD, you can quickly estimate 2 crucial numbers. First, the insulin correction factor, or ICF.
Yes, the ICF. It tells you how much 1 unit of insulin will lower the glucose. We use the 1800 rule for short-acting insulin. You just divide 1800 by the TDD.
So if the TDD is 60 units, 1800 divided by 60 gives you an ICF of 30. 1 unit drops glucose by 30 milligrams per deciliter.
Exactly. The other number you need for meal planning is the insulin-to-carb ratio, or ICR.
The ICR. And for that?
That uses the 500 rule. Again, for short-acting insulin, you divide 500 by the TDD. So the TDD is 60. 500 divided by 60 gives you an ICR of about 8.3. 1 unit covers 8.3 grams of carbs.
Okay, let's put that into practice. Say our patient with a TDD of 60 tests her pre-meal glucose and it's 150. Her target is 100. How do you calculate that pre-meal dose?
Okay, first, the correction. She needs to drop her glucose by 50 points from 150 to 100. Since her ICF is 30, she needs 50 divided by 30, which is about 1.7 units just for the correction.
And then you add the meal coverage on top of that.
You do. You use the ICR. If she plans to eat, say, 45 grams of carbs, you divide that 45 by her ICR of 8.3. That's about 5.4 units for the meal.
So you add them together. 1.7 plus 5.4 gives you a total dose of 7.1 units.
Exactly. That's the total pre-meal bolus.
That rigorous calculation really highlights why insulin is the gold standard. It's so precise. But what about the oral agents that are often tried first?
We primarily rely on 2. Glyburide, which is a second-generation sulfonylurea, stimulates insulin release.
Yeah.
Crucially, it does not cross the placenta in measurable amounts.
And metformin, we see it used a lot, but it carries a different warning in this context.
It does. Metformin works by inhibiting glucose production in the liver. The major distinction is that metformin does cross the placenta in appreciable amounts. And while it's convenient, the MIG trial showed it had a very high failure rate. 46.3% of patients ended up needing supplemental insulin.
Almost half. That's a critical insight. Nearly half will fail monotherapy and need to transition to insulin anyway.
That's right. And we should also note insulin pumps are mostly for established type 1 patients. We really don't recommend transitioning to a pump during pregnancy because of the steep learning curve.
Okay, let's shift to fetal surveillance. For patients who end up needing medication, so GDM-A2, type 1 or type 2, when does that specialized monitoring begin?
Monthly growth scans are initiated right after the 18 to 22-week anatomy scan and fetal echocardiogram. We're monitoring so closely because of the very real, very prevalent risk of macrosomia.
Macrosomia, defined as 4,000 grams or more, or over the 90th percentile.
Yes, and the numbers are staggering. It occurs in 42 to 62% of type 1 pregnancies and 10 to 20% of GDM pregnancies. That 62% figure for type 1 is huge. It just highlights the risk for complications like shoulder dystocia.
A huge number. So when does the routine antenatal testing start, and what are you looking for?
Antenatal testing, usually a modified biophysical profile, so that's a non-stress test, plus the amniotic fluid index. That should start between 28 and 32 weeks for type 2 or GDMA2. For type 1, often as early as 28 weeks. Twice weekly testing is the standard.
Can you just elaborate on the thinking behind the modified BPP?
Sure, the screening relies on looking at the fetus's physiological responses to potential hypoxemia. The non-stress test, or NST, is your acute indicator.
Checking for heart rate accelerations.
Right. And the amniotic fluid index, the AFI, is the chronic indicator. It reflects longer-term placental function. We're also on the lookout for polyhydramnios, an AFI over 25, which is a known complication.
Okay, so when it comes to delivery, the final step is maintaining tight glucose control during labor to prevent one critical neonatal complication.
Exactly. The goal is to keep maternal blood glucose tightly, between 70 and 110 milligrams per deciliter, for at least 4 to 6 hours before delivery. This is absolutely essential to prevent the fetus, who's used to high maternal glucose, from suffering severe hypoglycemia once the cord is cut.
And the timing of the delivery itself.
Poorly controlled patients should be induced by 38 weeks to mitigate those risks. But a well-controlled A1 GDM patient can typically be allowed to labor spontaneously after 39 weeks.
Then postpartum, everything just flips on a dime.
It drops precipitously. Insulin requirements plummet. Type 1 and type 2 patients usually go back to their pre-pregnancy dose, or even just half their pregnancy dose. GDM patients typically stop all medication and are just monitored on a regular diet.
And that immediate care transitions into the long-term outlook, which is just as vital.
It is. This is a huge public health issue. Women with a history of GDM are at a high risk for progressing to type 2 diabetes. So the gold standard is a 75-gram glucose tolerance test at the 6-week postpartum visit.
And then screening continues after that.
It does. The American Diabetes Association recommends repeat type 2 screening every 3 years after that.
We also see a clear benefit from promoting breastfeeding in this population. It's really long-term preventative medicine.
The benefits are dual. They reach both generations. For the mother, breastfeeding lowers blood glucose and insulin concentrations, which might delay or even reduce her risk of developing T2D. And for the child, it lowers their lifetime risk of obesity and type 2 diabetes.
Finally, before that postpartum visit is over, effective contraception counseling is paramount to make sure any future pregnancies are planned and optimized.
Yes, and this is guided by the CDC's medical eligibility criteria, or MEC. The key is to distinguish between diabetes alone and diabetes with vascular complications. Women with diabetes and vascular disease or end organ damage are classified as category 3 or 4.
Which means what for their choices?
It means combined hormonal contraception, the ones with estrogen, are generally inadvisable because of increased thrombotic risk. So we really push for progesterone-only contraceptives. And the highly effective, long-acting reversible contraceptives, or LARCs, like the levonorgestrel IUD, they're safe and effective. If we connect this to the bigger picture, the management of diabetes and pregnancy is this critical interplay of molecular biology, rigorous monitoring, and calculated individualized dosing. The stakes are just immense, especially when you recognize that poor glycemic control during that first trimester has irreversible consequences.
Before we wrap up, let's just cement that core mental math. Here's a quick review exercise for you listening. A patient uses a total daily dose of 60 units of short-acting insulin. Using the 1800 and 500 rules, what are her estimated insulin correction factor and her insulin to carb ratio?
Remember, use those rules as quick start mental shortcuts. For the ICF, you divide 1800 by the total daily dose. For the ICR, you divide 500 by the total daily dose. These numbers are just essential for bridging that gap between science and daily patient care.
So, what does this all mean? The data strongly shows that the mother's metabolic status doesn't just affect the 9 months of pregnancy. It fundamentally shapes the child's future health, potentially programming them for obesity and type 2 diabetes decades down the line. This deep dive really shows that maternal-fetal medicine isn't just about 9 months of care, it's about preventative medicine across generations. The earliest intervention truly yields the biggest payoff.